Yeah. So, good evening, everyone. Welcome to the Decoding GI HPB Oncology. So, it was an online educational program mainly for young uh, surgeons and oncologists. So, basically, we started this during the COVID times, and we were so uh, like motivated by the people when they showed interest. So we have been continuing this, and it's the 38th webisode. So we do 2 episodes per month. So we are doing almost for 2 years now, and we've covered almost everything in GI HPB oncology. So this is the last leg of the whole program. So now we are starting with colon cancer, and who is better than Dr. Sanjoy Mandal to brief us about colon cancer? So Dr. Sanjay Mandal is a GI surgeon and a GI oncologist. So specializes in GI oncology, and he is a senior consultant at AMRI Hospital, Kolkata. So since we will be talking about overview and management of colon cancer here, and Dr. Mandal's talk will be followed by Dr. Prasenjit Das's talk. Dr. Prasenjit Das's talk will be centered. So Dr. Prasenjit Das is a pathologist who's a GI specialist. He has written a book on GI pathology and he specializes in GI pathology. So when we were doing our training in AIIMS, so he was my thesis co-guide also, and he used to tell us about everything about GI pathology. So he is currently professor of pathology at All India Institute of Medical Sciences, New Delhi. And since molecular pathology is very, very important, so we obviously we need to know the clinical pathology. And in management of colon cancer these days, molecular pathology has become extremely important. So he'll brief us about that as well. So with this, and without wasting too much time, I would request Dr. Mandal to take over and enlighten us.
Okay, thank you, Dr. Nikhil. I'm extremely honored to be here, and it's great to hear that you're doing so much academic work in this. So very nice effort. And I'll start with my talk. I've been given the brief to speak on colon cancer overview and management. So since most of these participants here are students, I'll be very brief and to the basics. Now, when we talk of colon cancer, we always need to understand the perspective of bit of incidence in India. Now, data for India is not very forthcoming. This is the ICMR data that is showing. So, India is actually, compared to the West, is a low incidence country for colon cancer, but it still in males ranks about 8th in males and 9th in females. But what is more important is that if you see the graphs below, you will see that compared to the West, where the incidence of colon cancer is falling, most likely due to the screening programs which they have started, in India, the colon cancer is rising. Well, some of it is due to the population rising, but definitely in our case, in India, the incidence is definitely rising, both in case of those above 50 and in the younger colon cancer group patients. So that is something which we need to understand. And we need to understand also that probably in the near future, this is going to be even more important. The incidence of cancer is going to be more in India. Now, a bit about the screening modalities. Now, for India, we do not have any screening modalities. We generally follow what is the Western guidelines, and these not exactly cannot be extrapolated to the Indian context, but we need to understand it in perspective. Now, screening modalities which are available are the occult blood test, which is recommended in the West by the American College of Physicians as a 2-yearly test. And colonoscopy, which is a gold standard, is generally recommended as 10-yearly test in average risk individuals. But if you have patients who are higher risk, for example, patients who have the polyposis syndromes or fall in that group who are likely to develop malignancies, especially in this polyposis group or the hereditary non-polyposis cancer group, they would have to undergo colonoscopies more frequently. Now, the other screening modalities that we have are the CT colonoscopy. Now, you must understand that CT colonoscopy had come with a lot of fanfare, but it did not actually live to its expectations. And because compared to colonoscopy, it was also very cumbersome, but there is probably a specific role for CT colonoscopy, especially in patients where a complete colonoscopy is not possible because of the kinking of the colon, the scope is unable to pass, and you're not able to do a complete colonoscopy. Probably in these instances, a CT colonoscopy would be worthwhile. Also, the FDA has recommended a capsule colonoscopy for some of these patients, but the problem in most of these is that by the time the capsule reaches the colon, most of the time the battery power is lost, though we are getting better and better technical know-how and better battery power these days. So we can use this as a form of colonoscopy in patients where a complete normal colonoscopy is not possible. Then you have the newer modalities, which are the stool DNA testing and the blood DNA testing. Now, what happens is that tumor cells secrete the DNA. I mean, the DNA is found in stools. Some of it is secreted in the blood. And you have modalities now available, especially in the US, where you can do these testing for screening for colon cancer. Now, a bit about the risk factor. Essentially two types: lifestyle related, non-lifestyle related. In the lifestyle related, you have the age, smoking, obesity, diet related, and sedentary lifestyle related. In the non-lifestyle related, you have things like acromegaly or diabetes mellitus, patients who have had ureterocolonic anastomosis. These all patients would have increased predisposition to colon cancer. People who are immunosuppressed following cancer, following transplantation. Those who have family history, especially who have first-degree relatives who have had cancers. Then you have the inflammatory bowel disease, and you have a whole lot of group of the hereditary non-polyposis coli group, and you have the polyposis syndromes, the hell lot of polyposis syndromes which are available. Now, all these have a very high risk of developing colon cancer as these patients' age progresses. Now, most of our colon cancer patients, and I'm talking specifically of colon cancers, not the rectal cancers, these patients would present essentially with pain abdomen. Blood in stools is another symptom, and change in bowel habits is something which is very characteristic for this. Some patients would also present with non-specific anemia. You would have these patients suddenly falling at home due to dizziness, and when they brought to hospital and worked up, you just find anemia in these patients. And then when you do a colonoscopy or an endoscopy, then colonoscopy, you find a growth in the colon. Some patients may present with abdominal lump. Patients, especially those in the left side, more common in the left side, I would say, but happens on the right side, would have stricturing growths, which can lead to obstruction, can lead to distension, and of course, anorexia and weight loss would be the other symptoms. Now, when we talk of examination, obviously a thorough examination is definitely important, but specifically for colon cancer, a couple of things you need to look at. You need to see whether the patient has anemia. You need to look for a supraclavicular lymph node and other lymphadenopathies, and do a thorough abdominal examination. And most importantly, always do a per-rectal examination. Because even if the patient has undergone a colonoscopy where colonoscopy has been done, still anal canal cancer might be missed. Asynchronous anal canal cancer might be missed. So that is very important. We have burnt our fingers. We have come across instances where colonoscopy has been done by eminent gastroenterologists thrice in a patient, and still a growth in the anal canal has been missed. Because very important, when the gastroenterologist does a colonoscopy, he just lubricates the anal canal and shoves the scope in. He will not assess the anal canal or the lower rectum for a growth. Very important. So always do a per rectal examination for all your patients. Now, just skip this slide now. I'm sorry about the handwritten slide, but I couldn't find a better way of showing. Not very common in India, but still we do see colonoscopic cancer, which is picked up after a colonoscopic polypectomy. Now, some of the other patients would undergo a colonoscopic polypectomy, and you would find a cancer, especially a T1. If you have a carcinoma in situ, these patients would essentially be followed up. But if you have a T1 growth, then a couple of things you need to assess. You need to assess if the polyp is pedunculated, and if it is pedunculated, does it have favorable features? In other words, is the cancer well differentiated? Is the margin more 2 millimeters or more from the resection margin? Is there a lymphovascular invasion? And whether the specimen is fragmented or not. Now, if these good favorable features are there, these patients would essentially be followed up. But if you have unfavorable features, any of these features being on the negative side, then these patients should undergo a colectomy. All patients who have sessile tumors who underwent a polypectomy and have a malignancy should undergo a colectomy. Now, there is a role for alternative therapies like EMR and ESD or endoscopic submucosal dissections in poor risk patients or patients who are otherwise not fit for surgery. So surgery is the mainstay for these patients if they have unfavorable pathologies, unfavorable factors. Patients who are otherwise poor risk may go for an EMR or an ESD. Now, coming to workup, these patients would obviously have had a colonoscopy and biopsy, and obviously on colonoscopy, if you have had a growth in either the left or the right colon, you would look at what the biopsy is, but even if the biopsy is negative, you still would consider them as potentially malignant and you would work them up. Now, the essential workup for a colon cancer would be a CCT of the whole abdomen with or without, with a triphasic CT of the liver, preferably. A chest X-ray of the is essential. A lot of people would advise a CCT chest. It's desirable, but yes, a lot of people would say not required, because if you do not have liver metastasis, then very unlikely you would have metastasis to the lungs. So chest X-ray is good enough. You need a CCT, you need to look at the hemoglobin and an LFT, and obviously all the other workup which you need from the anesthesia point of view. Whole body PET CT is essentially for follow-up or for looking for recurrence, or when you're planning surgery in metastasis, or if it's a baseline, if it's a M1 disease and you're planning for neoadjuvant therapy, then you probably might need a baseline PET CT to look for all the metastasis for follow-up. So what exactly are the information we are looking at when we are doing the CT for the colon cancer? For students who are going into the exam, the size of the tumor is very important. Other is position. Now, very important to note is that colonoscopy is not a good modality for assessing where the position of the tumor is. In colonoscopy, there are two mainly fixed points. That's the IC valve and the anal canal. Everything in between is a gray area. So you cannot depend on the colonoscopy for the position of the tumor. And this is essentially the position of the tumor is assessed on CT. You need to see whether it's an obstructing growth or not, if there's stool dammed up behind the growth, because then the management would change. You would need to assess the lymph nodes, whether they're lymph nodes along the paracolic, along the main vessels, or they're retroperitoneal lymph nodes. You need to assess for adjacent organ involvement, especially adjacent small bowel infiltration, whether the ureter is infiltrated, duodenum, parietal wall, spleen, sometimes urinary bladder, etc. You need to look for liver metastasis, how many, how big, which lobes. These are very important. The ascites, peritoneal and omental deposits. In females, whether there are any deposits in the ovaries, and also assess the appendix, especially. You need, for example, a lot of patients might have an appendiceal malignancy and not a proper cecal malignancy. This is important because treatment of an appendiceal malignancy is different, especially in certain subcategories. Now, when you prepare for surgery in most of these patients, because colon cancer is essentially surgical disease, I'll go into a bit details in which patients you should go for surgery and which not. A preoperative blood transfusion if the hemoglobin is low, below 8. We generally do not transfuse patients if they're 8. You can reserve blood if a patient has a borderline hemoglobin, but for most cases, in case of colon cancer, we do not generally require any blood reserve because most of these surgeries are essentially bloodless these days. Bowel preparation is something which is controversial, and it is definitely probably not required for right-sided lesions, and also should be avoided when you have an obstructed lesion or a partially obstructed lesion, because it is in these patients that you can exacerbate the symptoms. One place where it probably should be done is if you have very small tumors, because during surgery, if you have small tumors and you have fecal matter along with it, it can get confusing and you're not sure where exactly the tumor is. So probably in these situations, you should get it done. But otherwise, bowel preparation is something which is controversial. Some people do it, some people don't. It's more of personal preference. But literature-wise, it has been shown that it does not make much difference. This is the colonic anatomy that you need to understand. and depending on where the growth is, what type of surgery you're going to do. So I'll be just a bit brief in this. Now, you have read this anatomy in your MBBS and in your MS. What is important is that if you have a growth in the cecal region, essentially you would perform a standard right hemicolectomy in which you would ligate the ileocolic vessels. If the right colic is present, mind it, right colic is not always present, you would ligate it, and the right branch of the middle colic. So the resection line would come somewhere in the proximal part of the transverse colon. If you have a growth which is higher up, probably in the hepatic flexure, then your transaction line would probably go, you would take the whole of the middle colic and your transaction line would come more in the distal side of the transverse colon. This probably you need to modify as you're operating on table, depending upon how the exact vasculature is. If you have a left-sided growth, it will be essentially a left hemicolectomy with ligation of the ascending branch of the left colic or whole of the left colic. If it's a sigmoid growth, then the sigmoid vessels are generally ligated and you would do what you call anterior resection in these patients. For a transverse colon growth, the approach is a bit different. If you have a transverse colon growth, you have the option of doing an extended right hemicolectomy where you take out the right colon with the transverse colon and do an ileo descending or an ileo transverse anastomosis. The advantage of that is that you don't need a bowel preparation in this, and if there is any occult growth in the proximal colon, this would be taken care of, especially if it's an obstructed patient. The disadvantage is that the ileocecal valve is lost. These patients tend to have a bit more of diarrhea and lifestyle problems are there, but a lot of patients get adjusted. So this is the, in short, what is the approach that we have for operating these patients. This is a table which I have given, essentially the same thing which I have said. And but there are certain special situations that you need to understand where the approach is a bit different. If you're dealing with patients who have hereditary non-polyposis colon cancers, those who fall into the Amsterdam or the Bethesda criteria, the approach would be to do a subtotal colectomy with an ileorectal anastomosis. If you're looking at an adenomatous polyposis, the polyposis coli syndromes, it is essentially a restorative proctocolectomy and a pouch anastomosis, or a total proctocolectomy with a permanent ileostomy. And the same would be for an UC, where you have come across dysplasia or malignancy in any of the specimens. So for UC, it is never a partial colectomy or a segmental colectomy. It would always be a total proctocolectomy or a restorative proctocolectomy. Now, since we know what surgery we are going to do, what are the options that we have for colon cancers? Now, obviously, we have the option of open surgery, which has been the gold standard all along. And we have the new kid on the block, or the new gold standard, which is probably the standard laparoscopic cholecystectomy. Then you have other concepts of complete mesocolic excisions. You can obviously single incision laparoscopic surgery is an option. Robotic is an option. There are other modalities which were there, never quite exactly caught on. You have laparoscopy with nose, which is natural orifice specimen extraction, and nose, just to complete the whole series. Obviously, there are significant benefits of laparoscopy. You all know them: less blood loss, less pain, earlier return of bowel function. You have earlier discharge. No difference in specimen quality in most of the series. Similar post-operative morbidity and mortality, better overall quality of life, similar local recurrence, and similar long-term survival. So laparoscopy has shown definite benefits. If you look at the trials which are available, they have shown a similar picture of better short-term outcome with similar long-term outcome. So laparoscopy is become more and more acceptable and almost the gold standard for colonic resections. This is just showing the long-term outcome for laparoscopy, which is similar in almost all stages A, B, and C vis-a-vis standard open surgery. And this is just a video I had. A patient who has undergone a right hemicolectomy, post-operative day 1, no epidural, only diclofenac intramuscular. You can see how comfortable the patient is. I don't think you can see this in an open surgery patient. The other thing that we need to understand for laparoscopic hemicolectomy or colectomy is the type of anastomosis that you're going to do. Are you going to do an intracorporeal anastomosis or an extracorporeal? There's a bit of controversy regarding this, but most studies have shown that there is actually no difference with regards to intracorporeal versus extracorporeal. Extracorporeal ends up taking probably a bit more longer time and the cost is more. So probably intracorporeal is preferable and most people would be doing an extracorporeal anastomosis. Now, when you're thinking of laparoscopy, preoperative planning is very important. You need to select your patients. Generally be aware of a patient who has a very small growth, especially a very small tumor, because it may not be very well palpable. And these are tumors where you probably should get your endoscopist, colonoscopist to mark that area with a tattoo, the tattooing, and also be careful about the very large growth because you may not be able to handle it laparoscopically. And obviously, when you want to take them out, you would need to make a big incision and you lose the advantage of laparoscopy. Positioning the patient is very important in laparoscopy. We use a lot of gravity, so strapping the patient securely, having right or left sides up, and generally try and avoid patients who are unlikely to withstand prolonged periods of extreme tilt. You have the usual contraindications of laparoscopy, patients not fit for general anesthesia or pneumoperitoneum, patients who have coagulopathy, hemodynamic instability. Very important for colon cancer, patients who are obstructed or partially obstructed and have dilated bowels would have lack of working space, and these are patients where you should avoid. And again, large tumors, patients who have adjacent organ involvement are places where you probably should avoid laparoscopy. Cannot avoid robotic surgery. Robotic surgery has its advantages: excellent visualization, steady surgeon-controlled camera, human wrist-like movements. There is filtration of physiological tremors. There's lack of fatigue for the surgeon, less steep learning curve, and decreased conversions. There are the disadvantages of lack of tactile feedback, increased time. There's a problem of docking and undocking. Operating in different quadrants is difficult, and obviously there is a cost disadvantage for laparoscopy. Now, I'm not a robotic surgeon, but those who do robotics would be able to infer better on this. But yes, robotics has certain advantages, but where does it stand vis-a-vis colonic cancers? It's very important. Most studies have shown that robotic surgery has actually failed to show improved outcomes in colonic surgery. It may add health benefits for a high volume surgeon, especially for surgeons who are older, because you are more comfortable. There is less head and neck and back pain. But apart from that, when it's head to head with laparoscopy, there are no clear advantages. Cost factors still remain an important deterrent for robotic surgery. Now, certain important considerations that we need to think when we are doing colon cancer surgeries. When to consider for a stoma? When would you consider doing a colostomy or an ileostomy in these patients? Obviously, patients who are obstructed, you would strongly think. There is a concept of on-table bowel preparation, but I'm not sure. I'm not comfortable with that, and I don't think most people are comfortable with that. Perforated patients, again, are candidates where you consider for a stoma. Candidates, patients where the tissue is very friable, sutures cutting through, patients having poor nutrition, low albumin, poor GC, poor ECOG scores are patients, especially where you should consider for a stoma, especially in patients where a possible leak would be extremely detrimental, and these patients would not be able to sustain that. These are the patients where you should consider for an upfront stoma in these. A word about colon cancer with obstructions. What is the approach? Resection with stoma is generally the treatment of choice. Though if you have a right-sided lesion, you can do a resection with iliotransverse anastomosis following a right hemicolectomy or an extended right hemicolectomy or even a subtotal colectomy. You might do a diverting stoma depending upon the situation. If the patient is very sick or you would think that a resection would be detrimental for the patient, he would not be able to take it, then only a diverting stoma is good enough. Bypass with iliotransverse anastomosis is another option. Colonic stenting has been used But the problem with colonic stenting is that it is difficult to do for right-sided lesions, transverse colon lesions, though people are getting better and better at it. But most such studies have shown actually poor outcome with stenting. So if the patient is not actually unfit for surgery, then only we would think of colonic stenting. Otherwise, I think for a fit patient, surgery is the treatment of choice. Just a word about perforation. The most common sites of perforation are at the site of the tumor and probably the cecum. These patients tend to have a worse prognosis. The perforation can be just a localized abscess or a free feculent peritonitis where the prognosis is very bad. But it's very important to understand that these patients, their treatment should be individualized. You need to understand where the tumor is, where the perforation is, how sick the patient is, and what would be the best outcome for the patient. So the treatment has to be very, very individualized for these patients. Just a word about adjuvant therapy. I think it's safe to say that stage 3 and stage 4 tumors should go for adjuvant therapy. Stage 2 with unfavorable factors or complications, for example, stage 2 who are obstructed or perforated, should again go for adjuvant chemotherapy. And all others, especially stage 1 tumors, should undergo just surgery, and they should be cured after surgery and put on follow-up. One important question, is there a role for neoadjuvant chemotherapy? Well, colon cancer had always been a surgeon's disease, but nowadays I think there is a subset of patients where it has been found that neoadjuvant chemotherapy definitely has a role, especially patients who have multi-organ involvement where resection of the organ, the associated organ, would be difficult. Patients who have heavy metastatic dose, they have essentially metastatic disease with significant metastasis, retroperitoneal node involvement. These are the patients who can go for neoadjuvant chemotherapy and downstaging if possible. Important to note that these patients should not be obstructed, perforated, or actively bleeding if they are going to go for chemotherapy. In conclusion, I'd still like to say that treatment of colon cancer is primarily a surgical disease, though multidisciplinary treatment is increasingly becoming important not for stage 2 or stage 3 tumors, but patients who are very early and very late. These are the patients you need to decide what exact treatment you're going to give, and it is here that the multidisciplinary treatment is more important. Laparoscopic treatment is currently becoming the treatment of choice. With this, I'd like to conclude, and obviously I'd like to invite all the students and everyone to participate in the upcoming ISGCon in Kolkata. With this, I'd like to thank Dr. Nikhil, and I'm happy to take questions. Thank you.
Thank you, Doctor. Thank you very much. It was such a comprehensive summary of overall topic, and I think it will be very, very beneficial for the students. And now, obviously, we have a couple of questions. Asit, are you around?
Yeah, I'm around, Nikhil. I'm very much around.
Yeah. So you had 2 things to clarify. So I think you can take over that conversation.
Yeah. Hi, Dr. Mandal. How are you? I'm sorry.
Hi,
I joined
Dr.
late,
Asit.
so...
Hello. How are you? Thank you.
And thank you so much for taking this session. I know you're very busy with ISGCon, and you could take your time out at such short notice. We are really grateful for you, and thank you for a wonderful talk. And,
thank you. My pleasure. Thank you.
And another thank you for extending the early bird registration for 15 more days. So lazy birds like me can register now.
Yeah, definitely.
So I had 2 questions for you, Dr. Mandal. One is that you said that the extracorporeal versus intracorporeal anastomosis, especially in the right-sided colonic tumor, or for that matter, any colonic tumor. What about the wound infection rates? What is literature says about that? And secondly, what is your personal experience? Because we have had a very terrible experience of bad wound infection whenever we try an extracorporeal anastomosis, especially because of economic constraints. So what is your take on that?
We used to have wound infections, but nowadays we don't, because whenever we do the extracorporeal anastomosis, we cover that area with a polythene. We actually use a camera cover and we place it between the colon and the wound walls. So by doing that, we have found that the wound infection rate is almost nil. So that is a modification that we have done. It's not very expensive. We just put that camera cover between that, and we take the colon out through that opening. So by doing that, we have found that the wound infection rates have dropped remarkably. And yeah.
So if I can intervene, I mean, so we have been using the wound protectors, the specially designed wound protectors that are available in market, which you have the 2 discs and which gives a very good protection to the wound. And despite using them for every case, we see quite a significant number of wound infections in extracorporeal anastomosis. So probably there is something that we are doing wrong, which we need to cover. But I believe even the literature suggests that wound infection rate is higher when we do an extracorporeal anastomosis. So when given a chance, we would rather do an intracorporeal rather than an extracorporeal. That is our personal preference. I think, Nikhil, if you have anything to add on to this, you can.
No, I totally agree. I mostly would want to do an intracorporeal.
Right. So, and the second thing I would want to clarify from you, sir, would be is that in HNPCC, you said that the standard of care still remains a subtotal colectomy with ileorectal anastomosis. I believe there is some data emanating now in past few years that says that you can even you can do some organ preserving surgeries, in which if you have a left-sided colon, you can do a left hemicolectomy, or right-sided colon, which are more common in HNPCC, you can do, and you keep these patients under strong surveillance, and organ preservation is something which is coming up in HNPCC. What is your personal preference, and what is your take on this, sir?
Agreed. I've seen that data, but my personal preference is that, because I don't know, in our setup, patient follow-up is a problem. Getting them to do a colonoscopy, full colonoscopy every time becomes difficult. So I would still go ahead and do an ileorectal anastomosis, do a subtotal colectomy. That way we can just do a sigmoid colonoscopy and get away with whatever surveillance we are going to do. So my preference is still doing a subtotal colectomy with an ileorectal for this group of patients.
Right, sir. So only 2 questions from my side, Nikhil. You can continue.
So we have one more question from Rashpal Thakur, and I didn't understand Rashpal's first question. Are you around, Dr. Rashpal? So I mean, Dr. Rashpal asked how much segmental resection concept is applicable in malignancy colon, which avoids the conventional margin concept. Can you understand it, Dr. Sanjoy?
I'm not sure. Segmental resection, I think what I'm not sure. Segmental resection means you need to take significant, take out the colon enough to have at least a 5 centimeter margin. I don't know if that is the answer he's asking. If you're doing a right hemicolectomy with a tumor, there has to be at least a 5 centimeter margin. So I don't know. And the second question is, what stapled iliotransverse anastomosis you prefer? Well, I would prefer a side-to-side isoperistaltic anastomosis. That is that is what I do. I would resect it with the staplers and then do a side-to-side isoperistaltic anastomosis. I think any anastomosis is good enough. You do it stapled, you do it hand-sewn. I don't think it matters. Whatever you're comfortable with it, you should do. That's all.
Exactly. And I think most of the thing. So, Dr. Sanjoy, a couple of questions more from that discussion is that, like, we talked about screening modality in the beginning.
Yeah.
And we understand that data or whatever screening we advise for colon cancer is based on Western data.
Exactly.
So what would you do if a patient asks? What would you advise?
If a patient asks, I would tell him that you can go ahead and screen, because in India, it's most of the time out of the pocket expenditure. So if a patient wants to get himself screened, definitely, no problem. I don't think you can withhold an investigation.
No, I didn't mean that. What I meant was that if the patient asks, should I get screened? Or like if a patient comes to your other patients, like, will you advise them screening or you will not advise them screening? What would you broadly do?
I have actually not come across a patient who comes and tells me screening. So I have never had to face it. But yes, for patients who have had the polyps, I would always advise them screening. Even getting them to screen is difficult. A patient who has had a polyp and resected, getting them to get the colonoscopy done every 2 to 3 years or 5 years is a difficult task. They would tell you, Doctor Sahab, karana hai? Do you really want? I'm fine. Patients who have had the malignancy, it is very easy to get them screened because they are already scared of that malignancy. Normal patients coming wanting a colon cancer are, to my mind, those who are very, finicky patients, and I think they're very few and far about. If they would ask me, I would tell yes, you can go ahead and get yourself screened. Definitely.
Dr. Nikhil, one question from my side.
Yeah, please.
Me or Dr. Sanjoy?
Yeah. So, sir, this is Dr. Shefali. So my question is, are you getting MSI also done in every patient who undergoes a surgery for CA colon, or it is a selected group of patients? So what is your take on MSI testing?
Our oncologists ask for it in every patient. So they would get the colon cancer panel done in all of the patients. At least unless the patient cannot afford or there's a problem, they would advise it for all our patients.
And would you go for the IHC
This is music
first or
to
a PCR?
Shefali's ears.
Yeah.
No, it's music to all of our tumor board persons' ears. I understand that concept. Okay, so is it IHC first or you go for PCR?
We go for IHC first.
IHC. Perfect. Sure. Thank you.
If I ask you a counter question, Dr. Shefali, why would you do MSI in all the patients?
So MSI, number one, you are able to fetch that Lynch syndrome category patients. Okay. Number second, in T3N0 specifically, where you wish to have an idea, okay, whether it can contribute to your decision making to plan adjuvant chemotherapy or versus observation. So these are two categories.
So I asked, why would you do in all patients? These category I understand.
Yeah, all patients means you may be able to screen those Lynch syndrome patients. Now they may not have
so 70-year-old gentleman with left-sided colon cancer. What is the probability of Lynch?
So index case can be any age, number one. Okay, so
what is the probability, Dr. Shefali?
5% only, not more than that.
So, I mean, yeah, low probability we can do, but in a resource constrained setting, probably we'll have to think twice before ordering.
That is why NCCN is now coming up to test it in every patient, like Sir delineated. That is why I wanted to ask. So in the version 2021, it was only in select group of patients, but now the consensus says it should be in every patient. That is how it is. Because sometimes once a colon cancer patient comes, he may have a history of, say, maybe any other Lynch-related malignancy in the family, which we may not ask on a usual routine. And that may be an index case for colon. So that is, I think, the mindset. I don't know, because this is now a routine recommendation in every patient of colon.
Yes. So I totally understand that this is a routine recommendation, but probably the context in which we are talking about is different when we're talking about the guidelines which are emanating from societies which are much ahead of us in terms of their socioeconomic conditions. So yes, in a setting in which mostly we work, probably it's not a bad idea, but recommending that to students who are from each and every corner of the country, I mean, they also need to understand why do we do MSI and which are the patients which are going to benefit from this.
Agreed.
Yeah. And one more question, Dr. Sanjoy, would be like regarding PET.
Yeah.
So obviously we do understand that CT is fine most of the time. And if you have metastasis, we would want to do PET. But what sometimes bothers me are the patient where the CT will say there are some perilesional stranding. So because that could be, peritoneal metastasis, and the management approach is totally different. Like when we are talking about colectomy and the next moment we are talking about cytoreductive surgery plus minus HIPEC and all that. So how do you tackle that situation?
I would normally, if you have a perinodal, if the CT shows localized, you're talking about the localized perinodal?
Localized perilesional stranding. Localized perilesional stranding.
I wouldn't get a PET in this. I would still go ahead with the standard CT and proceed with the standard surgery in this. And I wouldn't get a pet in this.
Probably yes. So we'll just hope and pray that it turns out to be
Yeah.
non-peritoneal metastasis. Yeah, fine. Good. So anything else, Dr. Shefali, or we move with the next presentation?
Yes, please. You please invite. We can move on to the next one.
Prasenjit, hi.
Hi, thank you. Let me share my screen. So at the offset, thank you, Dr. Nikhil, for inviting me in this forum. And I also think it is important for the budding surgeons also to get to understand some of the factors, and some of the questions are related to my presentation only. So I'll start with that. As already has been highlighted, colon cancer incidence in low socioeconomic country like India, it is much lower than the Western countries, but the incidences are rising in both less than 50 and more than 50 years age group. So first, I will touch upon what are the WHO tumor types we identify and how they are related with the prognosis. So this is the garden variety of adenocarcinoma. We call it adenocarcinoma NOS, as it has very nice glandular pattern. And and the other variants are mucin secreting adenocarcinoma. We see lots of mucin. But the criteria is if it contains more than 50% of the tumor area, we call it mucin secreting adenocarcinoma. Its prognosis is almost equal to the adenocarcinoma NOS, provided you do a MSI testing. If it is MSI microsatellite unstable, then the prognosis is almost like an adenocarcinoma. However, if it is microsatellite stable, then it has a poor prognosis. Another variant is the signet ring adenocarcinoma. You can see there are a lot of signet ring cells we can identify and infiltrate diffusely. And the criteria is we have to identify more than 50% of the tumor area having these atypical signet ring cells. Or both the mucin secreting as well as signet ring cell adenocarcinomas, they are mostly microsatellite unstable. So if your pathologist report these variants, always it is better to do microsatellite testing. Another new variants of adenocarcinoma, which have a relatively good prognosis, is that it is called adenoma-like adenocarcinoma. Why the name is so? Because you can see most of the tumor is projecting into the lumen, and at least the tumor should be superficial infiltrating only, and it has been seen this tumor usually doesn't perforate through the serosa, and the prognosis is quite good. This tumor we see commonly KRAS type of mutations. And next variant is the solid variant, which also is called medullary carcinoma. It is not that infiltrating. It has a pushing border, and it is surrounded by usually a lot of immune cells, mainly lymphocytes and plasma cells. It has a very relatively better prognosis. And here also we see commonly microsatellite instability, and these tumors show BRAF gene mutations. Another variant of the colonic carcinoma where we see very nice or a good outcome is that serrated adenocarcinomas. And this serrated, why we call it serrated? Because as you can see, there are prominent serrations like the kitchen knife edge in this tumor in all these glands. So in this also we see commonly methylations of various tumor suppressor genes, or they show commonly BRAF and KRAS gene mutations. So this has relatively better prognosis, but there are other variants which show very poor prognosis. If we see in a tumor, there are glandular area, and in more than 1/4 of the tumor, we see squamoid differentiation. We call it adenosquamous carcinoma. And here we see very poor prognosis. Sometimes we do not see any typical glandular arrangement. You can see all the tumors are very pleomorphic, and it is appearing a solid sheet. That is called undifferentiated carcinoma. In undifferentiated carcinoma also, they are microsatellite unstable mostly. There is another variant which you identify nowadays, that is called micropapillary carcinoma. There are small groups of tumor cells. They are surrounded by clear spaces. This tumor has also poor prognosis. They show more incidence of metastasis and lymph node positivity. Poorly cohesive carcinoma also show poor prognosis, and sarcomatoid carcinoma, which is a transformed carcinoma, we see spindle cell differentiation. That is also an aggressive variant of carcinoma. In WHO also says that in the colon and rectum, we can see neuroendocrine tumors. And as you all know, neuroendocrine tumors can be well differentiated neuroendocrine tumors where the histology is very characteristic and the prognosis is relatively better. And they can be poorly differentiated, and they can also be which we call as neuroendocrine carcinomas. And these neuroendocrine carcinomas and neuroendocrine tumor can be present together with other carcinomas like adenocarcinomas or squamous cell carcinoma that we call as menin, and high-grade menins also have poor prognosis. Now, if we talk about the major molecular pathways of development of colorectal carcinomas, there are three major pathways. One is chromosomal instability pathway. Chromosomal instability, as the name says, there can be there can be variations of the chromosome number, or there can be insertions or deletions of various genes. And most of the important is the APC gene, that is the predominant or the first gene that is affected in this pathway, followed by multiple other genes, and that lead to carcinoma. In microsatellite instability pathway, here we see microsatellite MMR gene mutations or suppression of the MMR genes by methylation. And we have serrated carcinoma pathway. I will touch upon each of these pathways in the subsequent slides. So this is the chromosomal instability pathway. This is the normal enterocytes. We see in this pathway, we see an adenoma carcinoma sequence. We see very small lesions first. These are microscopic lesions. We call them aberrant crypt foci. And if we do genetic analysis, we commonly see either APC gene mutation or KRAS gene mutation, because these are the initial mutations what we identify in this pathway. And if a patient has APC gene mutation, that is also called mutator phenotype, because it has been seen that mutation of this gene predisposes the patient to have other subsequent gene mutations. That's why it is called mutator phenotype. And you can see in the low-grade dysplasia and high-grade dysplasia and subsequent development of invasive carcinoma, other genes and pathways are affected, like there can be a mutation in the inflammatory genes like COX2, EGFR gene mutations. There can be inactivation of the P53 and loss of heterozygosity of the 18q. Now, chromosomal instability pathway tumors, they are most commonly left colonic carcinomas. And in this, we commonly don't see microsatellite instability, and also we don't see methylation or suppression of various tumor suppressor genes. Most importantly, these tumors have poor prognosis and they are resistant to taxanes. On the other hand, microsatellite instability pathway, we have either germline mutation of the MMR genes, or the MMR genes are MMR proteins are lost because of methylation. So but there can be two scenarios where we can identify microsatellite instability. One in the scenario of HNPCC, where there is a germline mutation, and also we can identify MSI in sporadic colorectal carcinomas. And these tumors are commonly right colonic carcinomas. And there are typical very important scenarios where MSI testing are important, because MSI high or MSI H tumors, stage 2 colorectal carcinomas, they usually don't require any chemotherapy unless there is a high risk factor. And also, as has been mentioned, in stage 3 N0 group also, you can decide based on the microsatellite instability. If it is present there, you can observe there is no requirement of carcinomas. Now, in MSI high metastatic carcinomas, they also respond well to immune checkpoint inhibitors. So microsatellite testing nowadays have become very important before deciding if you are going to treat the patient with immune checkpoint inhibitors, because MSI H tumors commonly show high PD-L1 and PD-1 expression, and they can be targeted very well. And I have already mentioned which tumors your pathology report can guide you, where you can choose to do MSI testing, like if your patient has mucin secreting adenocarcinoma or signet ring cell adenocarcinoma or medullary carcinomas or undifferentiated carcinomas. In these tumors, we must do microsatellite instability testing. But don't think that all these pathways, what I am mentioning, they are exclusive. Like for this example, I will like to say that in CIN pathway also, the tumors which has chromosomal instability, 25% of them also can show microsatellite instability. So microsatellite testing nowadays are becoming universal, the serrated carcinoma pathway. And we have two changes in serrated carcinoma pathway. One is CpG island methylation, that is also called CpG island methylation phenotype. What is that? CpG, the meaning is the C cytosine preceding guanine. So this motif is commonly present in the regulatory regions of the various tumor suppressor genes, and these areas are commonly undergo methylation. Methylation is the epigenetic phenomena. Due to methylation, there can be suppression of gene expression. So there are tests where various gene panel markers can be tested for methylation, like all these 5 tumor suppressor genes. So if 2 or more of these tumor suppressor genes are methylated or not expressed, that is called CIMP high phenotype, and these tumors usually show relatively better prognosis. Another phenotype for what we can identify in the serrated carcinoma pathway is the KRAS gene mutation or BRAF gene mutation. In BRAF gene mutation, commonly seen in sessile serrated polyps or adenomas. They are called sessile because they don't they project into the lumen, and these are sessile lesions. They have typical serrated morphology. On the other hand, KRAS gene mutation is common in traditional serrated adenomas. This adenoma means presence of dysplasia, and they are called traditional because like a traditional polyp, they are projecting into the lumen. So this is traditional serrated adenoma, and in them we commonly identify KRAS gene mutation. But what is common in both the lesions is that presence of this prominent serration. That's why they are clubbed together in these special pathways. And we know this 30% of the colorectal carcinomas can arise from these pathways, and these tumors may or may not show serrations, prominent serrations, when they develop invasion. So where we see serrated carcinoma pathway colorectal carcinoma, they are most commonly right colonic carcinomas. So as you can see, in the right colonic carcinomas, we can have high microsatellite instability, as well as we have all the markers of serrated carcinoma pathways. So they overlap each other. And based on this overlapping, we have a molecular phenotype where you can decide your patient is going to have a good prognosis or poor prognosis. Like if your right-sided colonic carcinoma is CIMP high, that means they have methylation of more than or equal to 2 tumor suppressor genes. They are also MSI-H phenotype, that is microsatellite unstable, and they have BRAF gene mutation, hotspot mutation. The patient is going to have better prognosis. If your tumor patient is having CIMP high phenotype with KRAS gene mutation and microsatellite stable, the patient is going to have a poor prognosis. So any tumor which is microsatellite stable, they usually have poorer prognosis, and KRAS mutation in this scenario will also tell you the patient is going to have a poor prognosis. In CIMP negative phenotype, that means in tumor where we don't identify methylation phenotype, the tumor are also going to have more poorer prognosis. So if you just summarize between our right and left colonic carcinomas, what we said, the right-sided colonic carcinomas, they will have MSI-H phenotype, and they can have high methylation phenotype, and but they can also have KRAS and BRAF gene mutation. This group of tumors are generally have good prognosis, and chromosomal instability or chromosomal number alterations or chromosomal alterations are usually low. And we have already discussed, we commonly see mucin secreting or signatoring or undifferentiated carcinomas in this zone, and this is more common in female. On the other hand, the distal or the left colonic carcinomas, they have more chromosomal instability, and they are low in microsatellite instability, that is they can be microsatellite stable, and also the methylation phenotype is low. And obviously they will have gene mutations of various genes we have already discussed, most importantly APC gene, and prognosis is usually poor. Now we'll talk about very briefly MSI testing. So what are microsatellite? Microsatellite are repetitive DNA sequences, and there can be multiple nucleotide which can be repeated. The number of the nucleotide can vary from 1 to 10, and there can be almost 5 to 50 repeats. As you can see, these are trinucleotide repeats, these are dinucleotide repeats, these are pentanucleotide repeats. So these repetitions can be seen both in the introns as well as in the exonic region. They may be functional or may not be functional. Why this repeat happen? Whenever there is DNA replication with the DNA polymerase, there are known slippage in this. When the nucleotides are added, there are multiple errors. So these errors are called microsatellites, and there are mechanism these microsatellite can be corrected. These errors can be corrected, and for that MMR proteins are important. So MMR proteins are basically acting as a doctor which correct the genetic abnormalities or DNA abnormalities during the replication, and MMR gene is very important. The MMR gene may not work if there is a germline mutation, what we commonly seen in Lynch syndrome. And there can be another scenario where there is no genetic mutation, but the MMR gene activity can be stopped or can be prevented, and MMR protein can be lost on IHC analysis, and that phenomenon is called DNA methylation, and that commonly we identify in sporadic colorectal carcinomas. So MSI testing, as you all know about the Bethesda guideline, this was we used to follow this previously. But if we see the current guideline, ICMR said you can choose your patients, but as has been already discussed, according to the NCCN guidelines and according to the EGAPP guidelines, nowadays MMR testing should be done in almost all patients, and at least in all patients who are having tumors who are aged less than 70 years. We have already discussed what is the therapeutic benefit of the MSI, and tumors which are MSI-H, that is microsatellite instable high, those tumors are going to have a better prognosis. Now, what are the methods? The most convenient and which is most reproducible is the IHC, but we can also do PCR analysis. So I am showing you two scenarios. This is a colonic adenocarcinoma where you can identify all three proteins which are expressed in the nuclei: MLH1, PMS2, MSH2, MSH6. So I'll interpret this case as MMR proficient. On IHC analysis, we never say this is microsatellite unstable or microsatellite stable. We call this MMR proficient when all four are positive. However, in this particular case, as you can see, MLH1 and PMS2 are positive, but MSH2 and MSH6 are negative. That is nuclear loss. And how do we know our test has worked? We compare with the lymphocyte. You can see lymphocytes are internal control and they are positive, but tumor nuclei are negative. So in this case, I will interpret as MMR deficient, and the definition is when at least more than or equal to one of these markers are absent in the nuclei, we'll call it MMR deficient. Also, we can use PCR based studies. So for PCR, the NCI National Cancer Institute, they say that we can use at least 5 microsatellite markers. So at least 2 can be mononucleotide repeats and 3 can be dinucleotide repeats. And based on these 5 markers, we can identify their expression either by electrophoresis, or we can use nowadays sequence-based studies and fluorescent markers. We can identify if there is any abnormality or deviation from the normal control. So if the deviation is present at least in more than or equal to 2 of these microsatellite markers, we call it MSI-H. If it is present in at least one of these markers, we call it MSI low. And if there is no abnormality or deviation present, we call it microsatellite stable. In recent guidelines, NCI says that it is better to use 5 mononucleotide markers, but it is also good enough. So microsatellite H and microsatellite L and MSS interpretation or terminology should only be used when PCR is done. Now, how the outcome of colonic carcinomas are, it depends on which factors. Obviously, histological factors, including their grade, their staging, most important. What are the different tumor types we have already discussed. The circumferential margin status in case of mesorectal excision, will not go into all those details, but tumor budding. Nowadays, it has become important to count the tumor budding at the tumor invasive border, and tumor buds are basically cluster of 1 to 4 cells which are present at the infiltrative border. So more tumor budding, the tumor is going to have a more aggressive phenotype. Also, perineural invasion, lymphovascular invasion, as conventionally mentioned, they are important prognostic factor, including extramural tumor deposits, and HER2/neu can be expressed in 5 to 10% or 15% maximum in colorectal carcinomas, but they are not routinely asked for, but they may be relevant in cases of colorectal carcinoma which are anti-EGFR resistant. In that case, if your tumor is 2+ or 3+ positive, at least 3+ positive, anti-HER2/neu therapies can be tried. Also, PD-L1 can be checked for there are various recommended clones, and they become more important if your tumor is having MSI-H phenotype or they are MMR deficient. In these cases, if the primary treatment hasn't worked, then as an alternative tumor approach or immunotherapy, consideration of immunotherapy, PD-L1 or PD-1 testing can be done. Now, most importantly, nowadays, comprehensive molecular subtyping is being used more for prognostic classification of colorectal carcinomas. And this came up recently, a few years back, based on the TCGA molecular phenotype of the colorectal carcinomas. And we have 4 comprehensive subtypes, 1, 2, 3, 4. The type 1 is microsatellite unstable phenotype. Type 2 is the chromosomal unstable phenotype. Type 3 is a metabolic phenotype where we identify more glucose metabolism disorders, and type 4 is inflammatory phenotype, and here it is also called the mesenchymal phenotype because of high EMT, that is epithelial mesenchymal transformation, and this has a very poor prognosis. So if we draw a line between these 4 types, the upper part, that is CMS type 1 and type 2, they have relatively good prognosis, and CMS type 3 and type 4, they have poor prognosis. Also, this classification is important because apart from the survival, the treatment response and treatment decision also depends on this. Microsatellite unstable tumors, as you all know, they can be resistant to only 5-fluorouracil. So in this, there is a combination therapy or FOLFOX therapy needs to be given. If at all in stage 2 tumor, you need to give a chemotherapy. And in these tumors, CMS type 1, there is a indication of checking for PD-L1 and PD-L1 for immunotherapy. CMS type 2, it has a very good prognosis. CMS type 3, as I said, there is a metabolic disorder, and these patients have a poor prognosis to FOLFOX in stage 3. So it is important to remember. And in this tumor, we have high mutation burdens, and HER2/neu expression is very high. So as they're resistant to FOLFOX, anti-HER2/neu therapy can be considered. And also you have to remember that this CMS type 3, they are also somewhat show poor response to anti-EGFR therapy, and alternative therapies can be considered like inhibitor of glucose transporter or various glycolytic enzyme like pyruvate dehydrogenase or tyrosine kinase inhibitors may be tried. Now, CMS type 4 is the inflammatory phenotype. We also have high mutation burden in this, and irrespective of the RAS gene mutation, this phenotype is completely resistant to the EGFR treatment. So that's why nowadays it is very much important to do molecular analysis to classify, categorize them, and in this anti-angiogenic factors can help as an alternative therapy. So as I have already told how the molecular workup should be done, that is required in all metastatic colorectal carcinomas and where you are considering anti-EGFR therapy. And as you can see, the RAS gene and RAF gene, they are downstream component of the EGFR pathways. So that's why if there is a mutation here, anti-EGFR therapy will not work. That's why before giving this therapy, we must look for this RAS gene mutation. And also see in this pathway, you can also see there is the EGFR gene receptor, there is a PIK3 kinase and PTEN also are components or regulator of this pathway, but there is no such recommendation of looking for this gene mutation, associated gene mutations before you give anti-EGFR therapy. So KRAS and NRAS both should be seen, and for both the genes, these are the exons, and these are the recommended by all molecular associations across the world. What we also do in our center routinely in patients who have metastasis for giving anti-EGFR therapy. And what are the modalities you can ask for? You can do allele specific or ARMS PCR, what we also do in our department, or it can also be done by Sanger sequencing or other high throughput sequencing technologies. And this is the recommendations of the CAP and also the molecular association of the American Molecular Associations. I have already indicated these codons and their exons, and you must remember that this looking at these gene mutations are very much important before we institute EGFR therapy, anti-EGFR therapy. If there is other molecular workup which is recommended, yes, we can do BRAF gene mutation, hotspot mutation, because BRAF gene mutation can be seen in 10 to 20% of the sporadic colorectal carcinomas, and we must know what are the different hotspots of the BRAF gene mutations, what we commonly follow. But for guidance, I can tell you in which situation BRAF gene mutation is not required. One is if you have done RAS gene mutation study in your case patient and they are showing RAS gene mutation, in those cases there is no indication of doing BRAF gene mutation study, because they go they show invertive, they are basically complementary to each other. So if there is RAS gene mutation, then BRAF gene mutation is usually virtually never seen. And also BRAF gene mutation is not required if your patient has MLH1 germline mutation, and we use this when this phenomena when we work up the patient for the Lynch syndrome. I will explain that shortly. So what are the different indications of BRAF gene mutation? So we use it as an intermediate step of when we work up the patient for Lynch syndrome. And BRAF gene mutation is a marker, is a prognostic marker. If your patient has mutation, then the prognosis is somewhat better than patient who has a wild type of BRAF gene. You can see if your patient has a deficient MMR, but BRAF is wild type, then the prognosis is somewhat poorer than the patient who has BRAF gene mutation. So BRAF gene mutation is having, the patient will have a relatively better prognosis. And if the patient has BRAF gene mutation, then the treatment response to anti-EGFR therapy can be a bit poor. However, there is no such recommendation to do BRAF gene mutation before giving anti-EGFR therapy. So that is not recommended yet. So as I have told, there can be two scenarios where your patient has microsatellite instability. Most 12 to 15% of your sporadic colorectal carcinomas can be microsatellite unstable, and also a part up to 5% of the hereditary colorectal carcinomas can have microsatellite instability. So you want to, if the patient is aged nearly about maybe 40 years, you want to work up for the Lynch syndrome. So how do we work up for the Lynch syndrome? Now we need to look for the germline mutation of that particular microsatellite genes. But germline mutation is always done by the next gen sequencing, and that is quite costly. So there is an intermediate step what we can do, because we still don't know MMR protein is lost by IHC, but if we need to directly do germline mutation, so what we'll do, we do a BRAF hotspot mutation study. If hotspot mutation is present, then it can never be a Lynch syndrome. If mutation is not present, there is a wild type of BRAF gene, then again we need to do germline mutation study. So that's how we can save some money, and we can use judiciously the next gen sequencing study while we are working up for the Lean syndrome. So this is almost second last slide to tell you how a minimalistic workup algorithm should work in a colorectal carcinoma. See, almost all colorectal carcinoma nowadays, you should advise for MMR protein. So that is not always for therapeutic decision, but it is also a prognostic marker. So it is both prognostic and therapeutic. So suppose you have done MMR protein by IHC and there is loss of MLH1 protein. So if there is loss of MLH1 protein in a 40-year-old male or female, you will like to look for Lean syndrome. So what you will do next, you will order for a hotspot BRAF gene mutation. If mutation is not present, next what you have to see, you have to see if there is MMR gene methylation, because I told you there can be only two mechanisms of MMR protein not being expressed, or there is loss of MMR protein. There can be germline mutation, or there can be methylation. If methylation is not present, then only you can go for next gen sequencing to look for germline mutation in the MLH1 gene. Okay, so this is one scenario. However, there are other MMR proteins which also can be lost. So if these are lost, you don't have to order for all these intermediate steps, and you can directly order for germline mutation. If there is loss of MSH2, then you can specifically ask for the germline mutation study of the MSH2. So this is how your minimalistic workup should work. Now, in metastatic colorectal carcinoma, if you are considering to give anti-EGFR therapy, then we must order for KRAS and NRAS gene mutations. It is purely of therapeutic benefit, and I have told what are the exons and what are the codons which are required. We need to screen. Now, last slide is which tissue is recommended for molecular workup. So this is in accordance of our preference. So it is recommended that if you have a metastatic colorectal carcinoma that is accessible for biopsy or sampling, that is the tissue you send to lab for molecular analysis. If that is not available, if the tumor has recurred in the primary site or in the anastomotic site, you can sample the recurrent tumor and send that for the molecular analysis. If even that is not accessible or that is not available, then only you can use the primary tumor site. Most of the time there is concordance, but as you know, there are driver mutations we develop which lead to tumor. However, there are many passenger mutations which accumulate till the time the patient has developed a recurrence or the patient has a metastatic tumor. That's why it is always preferable to use the metastatic site or recurrent tissue for molecular analysis. And you must remember that your FFPE tissue is good enough, or this is acceptable and recommended specimen sample for all these mutational studies, which is based on the extraction of the DNAs. So we can do, and we routinely do this, and that is good enough. So what are the take-home message of this short presentation? So histological typing is very much important. We must follow the WHO, because this histological classifications, they can give you some prognostic information, and you can do some ancillary tests like MSI testing or PDL1 testing based on the histological tumor type, and that can help you in therapeutic decision. The basic panel of MMR immunohistochemical markers are mandatory for prognostication and therapeutic decision in stage 2, not only stage 2, also in stage 3 in zero colorectal carcinomas nowadays, and it is very much important. And we must remember, forgetting all debates, all tumors should be screened for the MMR proteins. And analysis of the KRAS and NRAS gene mutations are mandatory in metastatic colorectal carcinomas, where only you are planning for anti-EGFR therapy, and their prognostic information is they have no prognostic information or implications. BRAF hotspot mutation, I have already explained where you should order. they have some prognostic information and helps in workup of the Lynch syndrome, how I have already explained. And for molecular analysis, always prefer metastatic site first, followed by recurrent tumor tissue, and then and always remember your FFP tissue is good enough, so there is nothing to creep on the not having any formally frozen tissue for the molecular analysis. So I think that is all from my end. So if there is any question, I will be happy to answer.
Yeah, thank you, Dr. Das, for the nice presentation and summarizing all of the aspects almost. You have not left anything. So
Thank you,
there was
Dr.
one.
Shefali. Yeah.
Thank you, sir. So there was one question in the chat box. I think you have very nicely described how to take forward the MSI testing in any setting. So one quick question, sir. So if there is no tissue available, so how validated and how confident we are on liquid biopsy to pick up these mutations, or for that matter, MSI, and can we use this information for deciding the therapy purpose?
See, liquid biopsy nowadays a point of interest, and there are multiple studies are going on both in India and abroad. However, at this scenario, we cannot say that at clinical setting, you advise your patient to have a genetic mutation analysis on the liquid biopsies. First of all, in the liquid biopsies, the number of the circulating tumor DNA or tumor cells are very less. So your lab should be expert, and the test should be validated and accredited before they are giving a mutation analysis on the liquid biopsy. So we have not reached, not only in India, in abroad also, to that point where you should rely on molecular analysis report on the circulating tumor DNA.
Right, sir. Right. Thank you so much. So I don't see any other question in the chat box. So just to wind up and summarize, I would like to thank Dr. Das and Dr. Mandal for taking out time to enlighten us on this very important topic. And thank you all the attendees to take out time to attend this. So we'll be taking forward the colon topic on the third Wednesday. The topic we have yet to finalize whether we would take a surgical topic or a neoadjuvant versus adjuvant. That we'll announce in our next message. And thank you so much for attending this important session. And thank you, sir. Thank you. Good night.
Thank you so much.
Dr. Nikhil,
It's a pleasure.
you want to add something? You are on mute. Please unmute. Please unmute.
Thank you, Dr. Shefali. I think it's time we go for rest of the evening. Thank you, Dr. Mandal. Thank you, Dr. Das, and thank you everyone for joining.
Thank
Good
you.
night.
Good night.
Thank you and good night.